Topic of the lecture today is cardiac myopathy. First of all, we have to know what cardiac myopathy is. Cardiac myopathy is actually pathologies of the myocardium which are exclusive of the extrinsic damage, of the extrinsic factors. It means it's going to be totally intrinsic. It's going to be totally inside the myocardium without any effect coming from outside the environment. So these pathologies accumulate and they form the major clinicopathologies, which are hypertrophic cardiomyopathy, dilated cardiomyopathy, restrictive cardiomyopathies. So all of them start from these basic myopathies which occur not because of an extrinsic factor, but because of intrinsic factor and pathologies occurring inside of it. So first of all, let's have a look at the normal heart. What we have to admire in this section, in this lecture, is the walls of the ventricles. There's the ventricle, there's the musculature of it. So you have to remember that this is the normal cardiac diagram. You can see this is the left ventricle, this is the right ventricle. These walls are thick, these walls are thin, and you have to know that this wall is thicker than this wall. You have to admire these things so that you can identify the pathologies lying behind them. So now this is dilated. You can see this is dilated cardiomyopathy. Why are we calling it dilated? Because left ventricle is dilated, this wall is thin, this wall is thin, and what happened to the right ventricle? It's down in its size. You can appreciate it. Look at that, and now look at that. Left ventricle has taken up most of the space. Next, now we have hypertrophy. We talk about dilated cardiomyopathy. Now, what's hypertrophic? Hypertrophic means there has been hypertrophy inside those walls. Look at them. This was a normal interventricular valve. Now, look at the interventricular wall here. Hypertrophied, increase in size, and now the size of the right ventricle has stayed the same, but the size of the left ventricle has reduced. Next, now we have restrictive cardiomyopathy. What will happen in restrictive cardiomyopathy? In restrictive cardiomyopathy, the pathologies don't lie here. The pathologies don't lie here, rather they lie outside of it. Rather they lie just outside of it. But still, there will be some consequence. There will be some consequence, and that you can see is increase in the size of interventricular valve, and this wall will stay the same in size. Otherwise, it's the same. So the difference we have to notice, we have to admire is in the valves. Look at the valves. Normal heart, what will happen in dilated cardiomyopathy? The left ventricle will dilate. It won't be able to contract properly. But the walls, look at the walls. Walls are thin. Right ventricle has decreased in size. Next on to hypertrophic. So the right ventricle is same in size, but the interventricular wall and the free wall of the left ventricle has increased in size. They have hypertrophy, and in order to compensate that, the size in the chamber of the left ventricle has decreased in size. And in restrictive, the pathology lies right outside of it, so not much has happened to the walls of the left or right ventricle. So what's the progression of the disease? Progression means how the disease will progress throughout the time, how the disease will progress through the time. So you can see in cardiac myopathy, what happens is that any kind of myopathy will lead to this cycle. This left atrium is giving the blood to left ventricle, and then this going to aorta. Now look at it. This is a normal. Now hypertrophy is happening. The walls are thickened now. They have hypertrophied. The chamber of the left ventricle has decreased in size. And with time, this hypertrophy goes away. They are dilated now. They are dilated now. They went into the necrosis. They are dilated now. They are dilated up to such extent that they won't be able to even contract properly. So this cardiomyopathy is further divided into some types. First of all, we're going to discuss about dilated cardiomyopathies. Then we're going to discuss restrictive cardiomyopathies. Then we're going to discuss hypertrophic cardiomyopathies and some minor types of them. So first of all, let's start with dilated cardiomyopathies. This name, dilated cardiomyopathy, gives off a lot. Dilated cardiomyopathies mean that this myocardium is dilated. The pathology of myocardium in which dilation has happened is called dilated cardiomyopathy. This is a normal heart, and the chambers are relaxed and fill and then contract and pump. Meaning the chambers are relaxed, they fill, then they contract and pump the blood out of the left ventricle into the bloodstream, into the body, where the vessels will provide the whole body, the whole cells, the whole tissues with the blood supply they need. Next on we have a heart with dilated cardiomyopathy. Now look at it. The size has increased. Now what happened to the chambers? Muscle fibers have stretched and heart chambers are now enlarged. As they're enlarged, they won't be able to contract properly. Next on we have pathogenesis of dilated and hypertrophic cardiomyopathies. So what's the difference between the pathogenesis of dilated and hypertrophic cardiomyopathy? The difference is very minute, because we talked about it that these pathogenesis must be intrinsic. There must be no extrinsic factor. And when we talk about intrinsic, what factors do we have? Genetic, epigenetic, or environmental. So the pathogenesis lies in the genetic code. The pathogenesis lies inside the body. So there must be a minute difference between dilated cardiomyopathies and hypertrophic cardiomyopathies. Among all of these cardiomyopathies, dilated cardiomyopathies lead with the major mortality rates. And the dilated cardiomyopathies lead to heart transplant. These are the only cardiomyopathies which lead to such level that it has to be transplanted again. Otherwise, the patient cannot go on. So in the pathogenesis of dilated and hypertrophic cardiomyopathies, there must be some genetic factors which lead to this disease. So let's talk about those genetic factors. First of all, let me show all of these structures to you so that you might get the idea of it, that what structures are going to be involved, or what genes are going to be involved, or what proteins are going to be involved in causing the pathogenesis of dilated and hypertrophic cardiomyopathies. So as you can see, this is the normal structures inside the cell. Now, first of all, in most of the cases, in 1 out of 3 patients, we have this genetic inheritance in Mendelian traits. You know the idea of Mendelian traits, right? So the patients get this disease from the parents in a Mendelian pattern, 1 out of 3. There has been multiple case reportings, and we know that multiple genes are involved in dilated cardiomyopathies, in the progression and leading to dilated cardiomyopathies. So first of all, let's talk about which genes are going to get affected, and in response to them being affected, which proteins or which structures get affected and lead to dilated cardiomyopathies. First of all, as you can see, 2 structures right here, lamina alpha 2, which is a further subtype of lamina A, lamina C, and next on we have desmins. Now desmins and lamina alpha 2 or lamina A, lamina C, those genes that code for these 2 structures, if they get mutated, they lead to dilated cardiomyopathies. So either the problem or the mutation lies inside the genes which code for cytoskeletal proteins or cytoskeletal structures. When they get affected, one way or another, this will lead to dilated cardiomyopathies. In some cases, those genes get affected which help in embedding these cytoskeletal proteins. Which structures might that be? Dystrophins and alpha-sarcoglycan. Now these get affected when those genes which code for alpha-sarcoglycan and dystrophin, when those genes are mutated, they lead to structural damage or structural mutation of alpha-sarcoglycan and dystrophin. Now you can see the pattern here. When lamina alpha 2, lamina A, lamina C, and then desmins, when those genes which code for these 2 structures get mutated, this leads to dilated cardiomyopathies. On the other hand, when those structures which embed these cytoskeletal proteins, which are alpha-sarcoglycan or dystrophin, when they are mutated, they lead to this kind of pathology. Next on, what other gene might get mutated and lead to dilated cardiomyopathies? Now, Titan, 500 cases have been reported. A small mutation inside the titan can lead to dilated cardiomyopathies. And there are multiple cases and multiple, you can say, scenarios in which if titan, which has so many further subtypes, if it gets mutated, it leads to this kind of pathology. Now let's talk about actin and beta myosin heavy chain and beta myosin light chain and myosin. All of these structures get affected when those genes which code for sarcomere, which code for these proteins, get mutated. The mutation leads to actin, myosin binding protein C. When all of these get affected, they will lead to both of these, dilated and hypertrophic cardiomyopathy. It won't lead to only dilated cardiomyopathy, it will also lead to hypertrophic cardiomyopathy. So here's the difference that we were talking about between dilated and hypertrophic cardiomyopathy. That in hypertrophic cardiomyopathy, the major pathogenesis, the major gene mutations lie right here. The major gene mutations affect actin, myosin binding protein C, beta myosin heavy chains. When these get affected, these lead to hypertrophic cardiomyopathy. On the other hand, when all of these cytoskeletal proteins, those genes which are coding for cytoskeletal proteins, being embedded by other structures, those genes which code for those structures which embed these cytoskeletal proteins, when they get mutated, they will lead to only dilated cardiomyopathy. And when these genes which code for actin, myosin binding protein C, myosin binding heavy chain, when they get affected, they will lead to hypertrophic cardiomyopathy. It will also include myosin light chains 1 and 2. You can see this right here labeled. So what we have is an idea in our mind that there are two kinds of gene mutations happening. First, those gene mutations which are affecting basically those cytoskeletal proteins and those structures which help embed them. When those are affected, only dilated cardiomyopathies are coming out of it. And when those genes get affected which code for actin, myosin binding protein C or beta myosin heavy chains, when they get affected, they will lead to hypertrophic cardiomyopathy. It will also include tropomyosin, troponin I. All of these are coded by those genes which in turn, when they get affected, they will lead to hypertrophic and dilated cardiomyopathies, both of them actually. Next on, we have the pathology of dilated cardiomyopathy. You can just look at this slide and tell that what's the pathology, what's the underlying pathology here. Now, this is the left ventricle, this is the right ventricle, right? What's happening in left ventricle? What has happened to its walls? What's happening to the right ventricle? What has happened to its walls? I'll give you a minute. Just look at it and you will know what's happening here. Just by looking at this photo, you will know it's dilated cardiomyopathies, because we talked about in hypertrophic cardiomyopathies, these walls are going to be hypertrophy. These walls are going to be huge. But in dilated cardiomyopathies, these chambers are going to be dilated. These walls are going to be thin and the pumping activity has been compromised. So what we see here is that left ventricle has a huge chamber, thin walls, and the right ventricle is not much affected. It's same in size. In some cases, the right ventricle size also increases, but in most of the cases, it stays the same. And the walls are thin. Now, the right ventricle walls are not affected that much, but the left ventricle walls are definitely thinner than they were supposed to be in a normal heart. Next on, we have clinical features of dilated cardiomyopathies. What features will the patient present to you with who is suffering from dilated cardiomyopathies? First of all, We just talked about this structure. This is dilated cardiomyopathy. These walls are thin. These chambers are huge. First of all, it begins insidiously. It means there won't be any predisposition to it. There won't be any symptoms to it. Just like, for example, we're talking about angina. For example, we're talking about myocardial ischemia. They don't begin insidiously. We have their risk factors present inside of the person. We have some degree of symptoms or signs coming out of that patient. But in dilated cardiomyopathy, patient won't even know it's happening because there's no extrinsic factor whatsoever. All of this pathology is happening intrinsically. All of this is genetic or epigenetic or environmental. Yes, environmental factors are there, but it's basically because of genetic predisposition. We talked about when the mutations happen in those genes which code for cytoskeletal proteins, or those genes which embed these cytoskeletal proteins, or those genes which code for actin, myosin, heavy chains, light chains, those proteins, when they get affected or mutated, now those mutations can be transferred from parent to child, or those mutations can happen in your life cycle, in your lifespan. Anyway, in any way, this will lead to dilated cardiomyopathy. And this dilated cardiomyopathy won't have any symptoms. It will begin insidiously. Next on, we'll have compensatory ventricular hypertrophy. Now, first of all, we talked about the progression of the disease, right? In the second or third slide, we talked about progression of the disease. We talked about how, in response to this pathology, hypertrophy will happen. This hypertrophy of the ventricles is called compensatory ventricular hypertrophy. What's compensatory ventricular hypertrophy? Compensatory ventricular hypertrophy means that ventricles are actually compensating. They are compensating this loss, because in this pathology, myocytes are being necrosed. There's death of myocytes, and myocytes are being necrosed, so the ventricles will go into hypertrophy due to the compensatory mechanism, so that they can perform the normal function. But what will happen eventually? This will lead to asymptomatic left ventricular dilation. Now, patients won't know about it because still the heart is compensating. Still the heart is compensating due to what? Hypertrophy. Heart is compensating due to hypertrophy, and this will be asymptomatic for a long time. In that asymptomatic phase, that hypertrophy will lead to left ventricular dilation. Now the muscles are being stretched. Now when the muscles are being stretched, what will happen to the pumping activity of the heart? We talked about it. When muscles are stretched beyond their limit, beyond their elastic power, they won't come back. You take a plastic, you take anything which is elastic in nature, you start pulling it apart. You're pulling it apart. At certain point, if you leave those ends, they'll come back together. They'll just snap together. They'll just come back together. But what happens if you stretch them way beyond their capability? They won't come back. They will lose their elastic power. That's exactly what happens in dilated cardiomyopathies. Now, due to this compensatory ventricular hypertrophy and due to this pathology, the muscle fibers have stretched and they've led to left ventricular dilation. When they will lead to left ventricular dilation, those muscles are unable to come back in a snap now. They're not working that properly now. So that will lead to exercise intolerance. Patient won't be able to run. Patient won't be able to perform those actions which require higher intake of oxygen, which require higher body functions. So patient won't be able to tolerate even the exercise, because for exercise, heart has to pump more and more blood to your muscles, to your tissues, so that the patient can exercise. Now, when those muscle fibers have stretched way beyond their capability, now they're unable to come back in a snap. Now they're unable to perform their function. When they have stretched far beyond their capability, now the pumping activity of the heart has been compromised. And when the pumping activity of the heart has been compromised, patient won't be able to get enough oxygen out of the blood, because now the left ventricle is pumping like not not proper pumping. It's not pushing enough blood. It's not pushing enough blood containing oxygen so that it can saturate those muscles, so that it can saturate those tissues, and the person can perform the exercise. Next on, we have frank congestive heart failure. Now, what's congestive heart failure? Not frank congestive heart failure. Heart failure means that heart is failing to perform its function. What's the function of the heart? To provide the body with enough blood containing oxygen so that it can perform its function, so that every cell, every tissue, every organ keeps performing its function. When heart is unable to do so because of this ventricular hypertrophy, because of this ventricular dilation, this will lead to congestive heart failure. Now the blood will start pooling. Now edema will start happening. Now heart won't be able to pump enough blood. This will lead to dilations and asymmetries, and this will lead to congestive heart failure. Next on, we have prolonged QT intervals. Why are we having prolonged QT intervals? Because due to this pathology, calcium influx and potassium, they are not managed enough. Now they are not up to the mark. Calcium influx is being stopped in some points, and it's being more in some points. Now potassium is being affected. When there's electrical imbalance, this will lead to prolonged QT intervals. Now these are the clinical features that you will look for in a patient which is suffering from dilated cardiomyopathies. So the patient will present to you and will say that I don't know what's happening to me. I was perfectly all right, and now I'm having all of these symptoms that I cannot exercise, I cannot run. Whenever I run, I go breathless. So you'll go for the test. You'll see that there's ventricular dilation present, there's ventricular hypertrophy present, and the patient is going into congestive heart failure. And when you will go for the ECG, patient is going to have prolonged QT intervals. Next on, we're going to talk about secondary dilated cardiomyopathies. What's secondary dilated cardiomyopathy? Let me tell you what primary dilated cardiomyopathy is. Primary dilated cardiomyopathy is due to genetic causes, due to primary causes. We talked about it's basically intrinsic. No extrinsic factor is going to affect it. So, to get those primary cardiomyopathies, genetic predisposition and genetic factors are involved. What's with the secondary dilated cardiomyopathies? Now, these are those factors which will lead to dilated cardiomyopathies, but these are secondary reasons, not the primary reasons. What are these reasons? First of all, alcohol abuse. Next, we have hypertension. Next on, we have pregnancy, viral myocarditis, diabetes mellitus, and cigarette smoking. Now, these are the secondary causes. These are the secondary predisposition of causing dilated cardiomyopathies. Alcohol abuse, hypertension, pregnancy, viral myocarditis, diabetes mellitus, and cigarette smoking. We're going to talk about all of these. So first of all, let's talk about toxic cardiomyopathy. What are the causes of toxic cardiomyopathies? First of all, it's going to be what? Ethanol. We just talked about alcohol, secondary predisposition. What happens with ethanol? Ethanol actually has a negative inotropic effect on the heart. Negative inotropic effect meaning that contractility goes down. So ethanol has negative inotropic effect. But what else does it cause? Its products, like when ethanol is broken down into its products, even those products have negative inotropic effect on the heart. And this toxic cardiomyopathy occurs when a patient keeps consuming alcohol for more than 10 years. So ethanol, what ethanol does is that it causes negative inotropic effects, plus it causes the necrosis of myocardium. When the necrosis of myocardium is happening and it has negative inotropic effect, it will lead to dilated cardiomyopathy. It will lead to toxic cardiomyopathy. So If a patient is consuming alcohol and having these symptoms, what we do, we ask the patient to stop the consumption of alcohol because these effects are reversible. If a patient stops consuming alcohol, patient will be all right after some time. Patient will recover from it. So there's no point in saying that there's no going back. Yes, there is going back in ethanol cases if a patient hasn't been consuming for more than 10 years. 10 years is a specific set point for toxic cardiomyopathy to happen. Next on, cobalt has the same effect. Cobalt also causes the necrosis of myocardium and stoppage, or you can say if the predisposition or exposure to cobalt has been is to reduce, patient will feel better afterwards. Next on, we have catecholamines. Now you must be wondering where the catecholamines come in. Catecholamines, yes, they're intrinsic, but the patients who are taking catecholamines to control their blood pressure, or patients who have pheochromocytomas, or the patients who had a head injury. Now, increased quantity of catecholamines above their set point will lead to myocardial necrosis, will lead to myocardial atrophy, and that will lead to dilated cardiomyopathies or toxic cardiomyopathies. Next on, we have anthracyclines. What are anthracyclines? Anthracyclines are actually chemotherapeutic agents. These chemotherapeutic agents have a set safety index. After that set safety index, they are going to cause toxic cardiomyopathies by directly affecting the myocardium, by directly affecting and destroying the myocardial cells. Next on, we have cyclophosphamide. Now, cyclophosphamide is given in those patients which are going to go under bone marrow transplant. If a patient is supposed to go under bone marrow transplant, that patient is going to be given cyclophosphamide. But yes, cyclophosphamide does not have any kind of direct effects on the myocardium and direct leading to toxic cardiomyopathies or dilated cardiomyopathies, but it does cause pericarditis, and that will eventually lead to this kind of pathology. Next on, we have cocaine. Yes, cocaine usage is also very dangerous. Cocaine also causes all of these pathologies. Cocaine, the certain level of cocaine, when they rise above those levels, they will lead to destruction and necrosis of myocardium. They will lead to this toxic cardiomyopathies and dilated cardiomyopathies, and this will in turn lead to congestive heart failure and so on. Next on, let's talk about cardiomyopathy of pregnancy. We talked about the secondary causes, so pregnancy is one of them. So cardiomyopathy happens in pregnancy. What's the timeline in which cardiomyopathy will be happening inside the pregnancy? It can either happen in the last trimester of pregnancy, between 6th and 9th month, 7th, 8th, 9th month, or it can happen afterward. It can happen postpartumly in the beginning 6 months after the delivery of the baby. So it has this 9-month window in which cardiomyopathy of pregnancy can happen. So what are the causes of cardiomyopathy of pregnancy? First of all, let me tell you, it can either be because of genetic susceptibility. Patients might have genetic susceptibility of getting cardiomyopathy of pregnancy. So either they can be genetically susceptible, or it can be because of pituitary gland, it can be because of endothelial injury, and it can be because of placental factors. So let's talk about pituitary. First of all, more and more prolactin will be produced. When more and more prolactin will be produced in this pathology, what happens is that prolactin will be broken down to an angiostatic N-terminal 16 kilodalton prolactin fragment. That's how I pronounce it. It's actually angiostatic, and it's attached to N-terminal, and it has this 16 kilodalton of weight. That's what we call it, 16 kDa prolactin fragment, right? It's done by cathepsin D. This reaction is carried out by cathepsin D. Now, once the 16 kDa prolactin fragment has been produced, what it does is that it causes the endothelial injury. When it causes the endothelial injury, this will lead to production of more and more 16K DA. It's actually a cycle. So it's going to affect the endothelium. On the same side, when endothelium is being affected, these cardiomyocytes are going to go under the stress. And when they're going to go under the stress, more and more reaction will be carried out. This will be carried out again and again. This will happen in a cycle. This will actually propagate. When this cardiomyocyte is undergoing this oxidative stress, because of this reaction, because of this endothelial injury, more and more reaction will be carried out, and more 16K DA prolactin fragments will be produced, and more endothelial injury will be happening. Now, when more and more endothelial injury is happening, what happens is that this fragment of prolactin, this 16 kilodalton fragment of prolactin, will further on give rise to miRNA 146A. Now, this is actually a messenger RNA of a microRNA. So it's not only an RNA, it's actually a messenger RNA of microRNA, and it has this 146 attached to it, because that's how we recognize this messenger RNA or microRNA. MicroRNA 146A, this is going to affect the cardiomyocyte and cause apoptosis. Now this apoptosis will be carried out, but at the same time endothelial injury is happening. When endothelial injury is happening, this will lead to microRNA 146A. This microRNA will in turn induce apoptosis. This injury will go on and on until the endothelial dysfunction happens. When endothelial dysfunction happens, this will lead to cardiomyocyte apoptosis. This message, this apoptotic message will go on, and cardiomyocyte will go under the apoptosis. Now at the same time, placenta is producing SFLT1. What is SFLT1? SFLT is actually some forms of tyrosine kinase. When these forms of tyrosine kinase 1 are being produced and their production is increased in this pathology, when this is being produced, this will in turn affect the vascular endothelial growth factors. When vascular endothelial growth factors are going to get affected, this will in turn lead to endothelial dysfunction. Now, if you look at this slide, 3 factors are affecting the endothelial dysfunction. 3 factors are affecting the endothelial layers, the cells, and causing endothelial injury and causing its dysfunction. First of all, we have this fragment of prolactin. Next now we have microRNA working on it. And now we have this tyrosine kinase 1, which affected the vascular endothelial growth factors, and they're also leading to endothelial dysfunction. And when endothelial dysfunction will happen, this will lead to cardiomyocyte apoptosis, and this will in turn lead to cardiomyopathy of the pregnancy. Now, what's the prognosis of cardiomyopathy of pregnancy? We have to know that in 50% of the cases, or more than 50% of the cases, those women, those pregnant women, or those women which have gone under the process of birth and it's postpartumly happening, they will go under the remodeling. They will go back to their normal structure. They will go back on their pathology, and the patient will be just fine. Patient won't be getting that pathology. But in some cases, this pathology does go on, affects the left ventricle, and leads to congestive cardiac failures. So it has both of these options available. It can either go back and the patient can be normal, or it can propagate and it can go further on to congestive cardiac failure. But once a patient has gotten this pathology and gone back on this pathology and is all right now, the reoccurrence chances are more and more. The patient can get this pathology again when it goes under pregnancy again. And in that case, or in that scenario, maybe it leads to congestive cardiac failure one way or another. And in this case, the death is imminent, or you won't even know that this is happening. The patient will present to you with these symptoms insidiously, and death is sudden in these cases. Next now we have hypertrophic cardiomyopathy. We talked about hypertrophic cardiomyopathy with the pathogenesis of dilated cardiomyopathies. We talked about when those genes which are responsible for coding of actin, myosin, those heavy chains, light chain, when those get affected, they will lead to hypertrophic cardiomyopathy. myopathy. Now, this is a normal heart. This is this mitral valve. This is a thickened left ventricular heart wall. Now, what's the difference between a hypertrophic cardiomyopathy and a normal heart? You can see these thickened left ventricular heart wall. Now, what will happen in a normal heart? This won't be thickened. This will be of normal thickness. This will be of normal thickness, and this chamber will be more in size. This chamber will have the capacity to have more blood inside of it. When hypertrophic cardiomyopathy happens, the interventricular wall goes thick and hypertrophied, and the free wall of the left ventricle goes extremely thick, extremely hypertrophied, and that's why this is the diagnostic point of hypertrophic cardiomyopathy, that this patient is going to have thickened left ventricular heart wall. So let's talk about the pathologies and these consequences. You can see now this is a diagram. You can see this is a photo of a patient, a gross structure of a patient who has gone under hypertrophic cardiomyopathy. What you can see is this free wall is hypertrophied, this interventricular wall is hypertrophied, and the chamber of the left ventricle has reduced in size. It has very low capability of entertaining more and more blood inside of it. So the capability of the blood in left ventricle has decreased because of this hypertrophy. Now it cannot have more blood, and when it cannot have more blood, it cannot pump more blood. When it cannot pump more blood, the body will have all of those symptoms we talked about, that exercise intolerance, because the body is not getting enough blood out of every pump, blood out of every heart cycle. And when it's not getting enough blood, it's not getting enough oxygen. So what happens is that this chamber is reduced in size, but these walls are thickened. When these walls are thickened, they have actually taken more and more of the size of the left ventricle. And these walls are thickened, and you can see the free chamber, the free wall of the left ventricle is hypertrophied, but not up to much extent. Rather than we look at the interventricular wall, it has thickened up to a major level. So what's going to happen? It's going to impede the blood going out of this wall. It's going to impede the blood supply which the body is going to get. So it's not only hypertrophied, it's actually impeding the blood circulation. It's actually impeding the blood going out of the left ventricle. Now this is a depiction, this histological diagram. As you can see, this interstitial cells have increased in size and hypercellularity is visible. Hypercellularity happens and interstitial cells go more and more in size. Now what's this? This is actually a diagram of your coronary vessels. What happens in hypertrophic cardiomyopathy, that it also can include your coronary vessels. When your coronary vessels are included, when your coronary vessels are affected, there vasospasm can happen, there spasm can happen, or something like that, and the blood supply of the heart will be compromised. And when the blood supply of the heart will be compromised, this will lead to myocyte degeneration or myocardial ischemia in some cases. So what you can see in this diagram is that the lumen has gone narrow in size, the lumen is not up to much extent, and hypercellularity is seen, hyperplasia is seen in this slide. Next on, we have hypertrophic cardiomyopathy's clinical features. What will be the patient presenting to you with? Now, after learning the pathologies lying behind the hypertrophic cardiomyopathies, after learning the structure which are going to get damaged, you must be able to interpret the clinical features coming out of hypertrophic cardiomyopathy. So let's talk about it. First of all, the patient is going to get dyspnea. Why the patient is going to get dyspnea? Because that left ventricle, the chamber of the left ventricle is not up to that level that after every pumping, after every ejection fraction of 60%, the blood is not enough to saturate the whole body. The blood is not enough. The blood is not enough to saturate the whole tissues. When it's not enough, it's not containing enough oxygen. So not every tissue, not every cell is getting enough oxygen. The patient will be dyspneic. Next on, the patient will have angina pectoris. Why the patient is having angina pectoris? We just talked about it. When it involves the coronary vessels and their lumen is narrow in size, the patient is going to have these angina pectoris. The patient is going to have these pains which will start from this substernal level and go up to the level of your left arm and up to the level of your fingers, and it will go up to your jaw. And this episode must be less than 15 minutes, because that's what the criteria of angina pectoris is. If it's lasting more than 15 minutes, it's going to cause myocardial ischemia. Next on, the patient is going to get syncope. It will happen suddenly. Patient won't even realize it's happening. And the first management of syncope is to bring that patient to the hospital so it can be managed. The patient will get syncope in this pathology of hypertrophic cardiomyopathy. Next on, we have congestive heart failure. So if the patient is getting dyspnea, if the patient is not getting enough blood, the patient is not getting enough oxygen, this will in turn lead to the consequences. This will in turn lead to the consequences which will lead to congestive heart failure, which will lead to pooling of blood. The heart won't be able to function enough. The heart won't be able to pump enough blood. So this will lead to heart failure and in turn lead to congestive heart failure. Next now we have diastolic dysfunction. What does that mean? Diastolic dysfunction means the blood won't be able to fill inside the heart. The heart won't be able to fill the blood inside of those chambers. So the patient is going to have diastolic dysfunction because those walls are thick and hypertrophied. Next now we have mitral regurgitation. Why are we going to have mitral regurgitation? First of all, where is the mitral valve? Mitral valve is present between left ventricle and left atrium. So mitral regurgitation is going to happen because of that hypertrophy, and when the left atrium is going to push the blood into left ventricle and try to pool the blood in left ventricle, what's going to happen is that mitral regurg will happen. Mitral regurgitation will lead to going of that blood from the left ventricle back to the left atrium because it does not have enough space for all of that blood coming in. So this will lead to mitral regurgitation. Next on we have atrial dilation. Why are we having atrial dilation? Atrial dilation is happening because left ventricle is, as you can see in this slide, left ventricle is so decreased. The chamber of the left ventricle is so shallow and so decreased now that it cannot contain all of that blood. So mitral regurgitation happens and that blood goes back to left atrium. When left atrium has that blood coming out of left ventricle and the blood coming out of pulmonary vasculature, now both of those blood supplies are coming in the left atrium. So in response to that, left atrium will enlarge in size. Left atrium will dilate so that it can contain all of that blood coming back from left ventricle and coming back from the pulmonary vasculature. Next now we have functional obstruction of the left ventricular outflow tract. We talked about it, that its hypertrophy is going to be up to such extent that this will lead to left ventricular outflow tract obstruction. And when that will happen, patient is going to go into ischemia. Patient won't be able to get the blood out of those heart valves. And when it's not happening, patient might die in that process. Next on we have arrhythmogenic cardiomyopathy. Whenever the name arrhythmogenic cardiomyopathy comes in front of you, one thing that you have to remember is the desmosome. It's actually desmosomal gene mutation which leads to arrhythmogenic cardiomyopathy. The name gives off arrhythmogenic. It's going to get arrhythmias. Arrhythmogenic cardiomyopathy. So the desmosomal gene mutations happen in arrhythmogenic cardiomyopathy, but it happens because of basically three reasons. First of all, we have desmosomal remodeling. We have nuclear signaling, which will lead to myocyte death. What will happen in desmosomal gene mutations? These desmosomes will be remodeled. When these gene mutations happen, nuclear signaling will lead to myocyte death. This will lead to fibrogenesis and adipogenesis, and this will lead to myocyte transdifferentiation. These all lead to structural changes which will lead to arrhythmogenic cardiomyopathy. Now let me explain that to you. First of all, we talked about that these are actually desmosomal gene mutations, right? So when genes are mutated, what's going to happen? Remodeling of the desmosomes will happen because now the genes are mutated, they're going to get remodeled. On the next sign, when these genes are mutated, nuclear signaling is different. This will lead to myocyte death in some cases, in some signaling. Otherwise, it will lead to fibrogenesis and adipogenesis. Those normal cells are going to die, are going to get necrosed, but what will happen is that adipose tissues and fibroblasts, they're going to get accumulated, they're going to produce, or they're going to get formed in places of those dead cells we talked about. Those myocytes which are dead will be replaced by fibrogenesis and adipogenesis, will be replaced by fibrous cells and adipose cells or tissues, and this will lead to myocyte transdifferentiation, and this all will lead to structural changes which will actually incapacitate the heart. The heart won't be able to function properly because some myocytes are dead and some are replaced by these structures. So the heart is not acting properly because its structural differentiation is not up to the mark. It does not have all those myocytes. It's been replaced by some other structures. So this will lead to arrhythmogenic cardiomyopathy. On the other hand, we have these gap junctions which will lead to arrhythmogenic cardiomyopathy. They will also be the consequence of desmosomal gene mutations. Next on, we have arrhythmogenic cardiomyopathies pathology. As you can see, what is the major pick point in this diagram? This is left ventricle, this is left ventricle, this is before the disease, this is after the disease. Now this is the right ventricle, this is the right ventricle. What changes are you looking at? Yes, you're right. Right ventricle is going under hypertrophy. Now, when this disease was diagnosed or first, identified, people thought it's a disease of right ventricle, not the left ventricle, because not much is happening inside the left ventricle, but more of it is happening inside the right ventricle. But with time, we know that it's a biventricular disease. It affects both of them. And because it affects both of them, we have to differentiate that which ventricle is being affected more. So we call it that arrhythmogenic cardiomyopathy with left ventricular dominance. It means the left ventricle is being affected more. On the same side, we call it right ventricular dominance. So in arrhythmogenic cardiomyopathy, that the right ventricle also gets affected. The right ventricle also goes under hypertrophy. Next on, we have pathological slide of arrhythmogenic cardiomyopathy. You can see this is the normal structure of heart, which has been, these are the myocytes which have been taken up by these adipose tissues with these fibroblast cells. Now these myocytes are replaced by these adipose tissues, these fibroblasts and other cells whose function is not to contract, whose function is not to pump the blood out of it. They are merely there as filling points. They're just filling the points of those myocytes which went under necrosis because of that nuclear signaling we talked about. And when they have gone under, under death, so adipose tissues and fibroblasts took over, and now those myocytes are replaced by fibroblasts and these adipose tissues. Now you can see, you can actually admire these structures which have replaced those myocytes. Now what will happen? The function of adipose tissue is not to pump the blood. The function of fibroblasts is not to pump the blood. So what will happen? They're just merely occupying the place, and the cardiac function went down. And this will lead to arrhythmias, and this will lead to arrhythmogenic cardiomyopathy. Next on, we have restrictive cardiomyopathy. What are the etiological factors for restrictive cardiomyopathies? First of all, we have amyloidosis. Next on, we have endomyocardial diseases. Next on, we have genetic and storage diseases. And then we have markedly increased interstitial fibrous tissue. Now, these four are the etiological factors which will lead to restrictive cardiomyopathies. What's actually restrictive cardiomyopathy? It's actually restricting it. So, amyloidosis, endomyocardial diseases. How does endomyocardial diseases affect and lead to restrictive cardiomyopathies? When endomyocardium is affected, this will lead to restrictive cardiomyopathy one way or another because it's being restricted. Genetic diseases, yes, if there's any genetic susceptibility to it, if there's any gene being affected which codes for some kind of proteins or which code for some kind of structures inside of it. This will lead to restrictive cardiomyopathy, storage diseases, which will lead to restrictive cardiomyopathy, and interstitial fibrous tissue will lead to it. Next on, we talked about etiological factors. Now let's talk about how those etiological factors are coming into the play of pathogenesis of restrictive cardiomyopathy. We talked about amyloidosis, right? So how does amyloidosis lead to restrictive cardiomyopathy? We talked about sarcoidosis. How does that lead to it? So first of all, amyloidosis and sarcoidosis lead to the infiltration of myocardium by pathological proteins. In these pathological consequences, the proteins are produced. These pathological proteins are going to infiltrate the myocardium. When we talked about all of these pathologies we're talking about, these are actually pathologies of myocardium. And if any harm is to come to the myocardium, this will lead to cardiomyopathy. So in these two diseases, in amyloidosis and in sarcoidosis, pathological proteins come in and infiltrate what? Infiltrate the myocardium. This infiltration and dysfunction of conduction system will happen. This in turn will lead to arrhythmia. When the myocardium is affected and infiltrated by these proteins, that pumping activity is compromised and this will lead to arrhythmia. At the same time, endomyocardial fibrosis will be cause of it, but before we go on to it, we have to know what hemochromatosis, how hemochromatosis affects and lead to this pathology all over again by different mechanism. In hemochromatosis, gene mutation leading to increased iron absorption and increased iron levels happen. We have all seen those patients which suffer from hemochromatosis, right? We see their iron levels are not up to the mark, but above the mark. So when gene mutation happens and they uptake a more and more amount of iron and absorption is more and the iron levels inside the body is more, this will lead to iron deposition as hemosiderin in organs such as heart. So this iron now, which is more and more inside the body, where will it get stored? Where will it get deposited? It will get deposited inside the organs. It's not that only heart is going to be that organ, it's going to be any organ. But when it gets deposited inside the heart in the form of hemosiderin, this will lead to endomyocardial fibrosis. That in turn will lead to what? Infiltration. That in turn will lead to arrhythmia. So these are three different pathological consequences coming from three different pathologies. So all of these will lead to arrhythmias. But what happens is that these amyloidosis, sarcoidosis, and hemochromatosis, when all of these are combined and all of these consequences are combined, this lead to stiffening of the left ventricular wall and diastolic dysfunction happen. When the wall of the left ventricle, which is comprised or made up of myocardial cells or made up of myocardium, when they get affected by either pathological protein infiltration or by fibrosis of endomyocardium or by absorption of iron or deposition of iron, all of this will lead to left ventricular thickening. All of this will lead to left ventricular stiffening. When the left ventricular wall is stiffed, when it's stiffed, diastolic dysfunction happens. What's diastole? Diastole is relaxation in which the heart fills, in which the blood fills those chambers. When diastolic dysfunction happens, the heart does not have enough blood to pump in the systole. So what happens is that increased ventricular pressure during diastolic filling phase will happen. Right? Why is that happening? Because stiffening of the left ventricular wall has happened and diastole is dysfunction. When diastole is dysfunction, ventricular pressure will go up during diastolic filling space. Ventricular pressure will go up to fill that gap, to fill that space. Next on, the pressure, increased pressure propagates to the right heart. Why is it propagating to the right heart? Because this circle goes a long way. When increased pressure of the left ventricle and diastolic phase is happening, it's going to affect the left atrium, which in turn will lead to those pulmonary vasculatures and will lead to right side of the heart, and it affects that heart. So what happens is that increased venous pressure will come in and this will lead to right heart failure. Increased venous pressure will come in. Why? Left ventricle, first of all, left ventricle, it's stiff. it's not taking blood in, it's in diastolic dysfunction. Increased pressure is happening. What will happen to the left atrium? Gets affected. This in turn will go back, affect the pulmonary vasculature. When the left ventricle is not taking the blood, when the left ventricle is not accepting the blood, what's happening to the left atrium? It's increasing in size. But it's not up to that mark that it can take all the blood in. So it's going to affect the pulmonary vasculature. It will stop taking the blood in from the pulmonary vasculature. So when the pulmonary vasculature blood is denied of entry into the left side of the heart, what will happen? It will put more and more pressure on the right side of the heart. So the right ventricle, which is pushing the blood into the pulmonary vasculature, that will go under pathological consequence, and that will go to the right-sided failure of the heart because of venous pressure will go up and up afterwards. This will lead to hepatic congestion because it's not taking the blood in, its venous pressure goes up. Now, when that right ventricle is affected, or right atrium is going to get affected, and all the blood supply coming from the different organs, coming from the vena cavas, that will be going under a lot of pressure and a lot of resistance, and that will lead to hepatic congestion. What will be the symptoms you will be looking for in this patient? Patient will have elevated JVP, right? Patient will have ascites, patient will have hepatomegaly, and patient will have peripheral edema. Elevated jugulovenous pressure. JVP stands for jugulovenous pressure. Elevated JVP will come in. Why? Because the venous pressure has gone up to certain levels, and now you can actually, here's where you can look for elevated JVP. You will see it's pulsating. You will know that patient is having elevated JVP because venous pressure is rising and rising, and it's up to that mark that we can actually see the JVP, and we can actually know that patient is going into right heart side failure. Ascites, why ascites is happening? Ascites is happening because pooling of the blood is happening. When right atrium is not even getting the blood from the venous system, and it's under a lot of pressure, the blood will start pooling in inside those veins. When the blood will start pooling in inside those veins, fluid will leave the vessels. When the fluid will leave the vessels in the abdomen, it will lead to ascites. In the foot or in the peripheries, it will lead to edema. Hepatomegaly will come in because of hepatic congestion. And next now we have peripheral edema. I just told you that when that fluid leaves the vessel inside the abdomen, it will lead to ascites. And when that fluid leaves the vessels in the peripheral areas, it will lead to peripheral edema. Next on, this stiffening of left ventricular wall and diastolic dysfunction led to all of this. What is the second and the basic pathological consequence of it? Impaired ventricular filling will happen. Obviously, when the ventricle is filled and it's not taking enough blood in and it's in diastolic dysfunction, impaired ventricular filling will happen. That will lead to decreased stroke volume. First, we talked about the consequences which are going to happen before the left ventricle. Before the left ventricle, we talked about left atrium is going to get affected, pulmonary vasculature is going to get affected, right ventricle is going to get affected, right ventricle is going to get affected, right heart side failure will happen. And then further on, we talked about that this will increase the venous pressure. We will see JVP, we will see hepatic congestion, we'll see edema, we'll see ascites. Now let's talk about what's the propagatory pathology coming in. What will happen to the body which is expecting the blood from the left ventricle? So impaired ventricular filling will happen. This will lead to decreased stroke volume because not enough blood is there. Stroke volume was supposed to be up to certain levels to satisfy the whole body with blood and oxygen supply. When that is affected, when that is compromised, this will lead to decreased stroke volume. This will lead to decreased cardiac output. Cardiac output is not up to that mark. This will lead to decreased muscle perfusion. Now the muscles are not getting enough blood. Now when the heart pumps the blood, first of all, blood goes to heart so that it can keep pumping. Then it goes to the vital organs, then it goes to the muscles, then to the tissues, then to the cells. So in order of preference, the blood is supplied to the body. So the muscles are perfused low. This will lead to fatigue. Tissues will go into hypoxia and they will stimulate the person to breathe. So the patient will be dyspneic. and patient will go under tachypnea. So what is tachypnea? Increased heart rate. Dyspnea, patient is unable to perform any kind of function. The patient walks 2 steps and patient is like, because tissues are not perfused enough, because tissue perfusion is low, tissues are not getting enough oxygen, and when they're not getting enough oxygen, they're unable to perform their duties. So we talked about what happened before the left ventricle that led to this pathology. Then we talked about what's going to happen afterwards. Hypoxia is going to happen, fatigue is going to happen, muscle perfusion is going to go low. Up to certain levels, heart continuously provides the basic organs, the vital organs, with the blood supply they need, and it compromises these muscles and tissues, and patient will have fatigue and dyspnea and tachypnea. But what happens if it goes beyond that level? If it cannot now provide the vital organs with that blood supply, then the organ failures will come in. Next on, we know that ventricular wall compliance has gone down. This will be easy to fill initially, but suddenly very hard to fill. Now, why is it hard to fill now? Because the compliance has gone down. Compliance is actually response of any vessel or response of any compartment to the blood coming in, so that it can either dilate or not. So if the ventricles are stiff, they're unable to dilate, the compliance is down, so it will be very hard to push those walls away and to fill more blood into it. So it will be very hard, and that will lead to prominent JVP. And on Y descent, you can see the peak and plateau. Peak at the point where you get the blood in, and plateau where it cannot expand anymore. So the ventricle walls, when they get this low compliance and they are stiff, atrium is going to contract and push the blood into the ventricle, and that will lead to the heart sound we call as 4 heart sound. Now, with these two consequences of easy to fill initially and suddenly very hard to fill, we have dip and plateau pressure tracing in ventricles when you look at the graphical presentation of restrictive cardiomyopathy. Now let's talk about sudden cardiac death. We have learned about all the pathologies of heart up till this point. So what are those pathologies that lead to sudden cardiac death? Let's talk about these causes. First of all, 48% of them lead to hypertrophic cardiomyopathy. Next on, 18% leads to idiopathic left ventricular hypertrophy. Next on, we have 14% of coronary anomalies, 7% of ruptured aorta, 3% are unexplained up till this point, and coronary heart disease load for 10%. Now let's talk about it. Why 48% hypertrophic cardiomyopathy? Because it's asymptomatic. We don't know that it's happening inside your body, so you won't even know. So what we talked about, that hypertrophic cardiomyopathy, in hypertrophic cardiomyopathy, the interventricular wall is so hypertrophied, is up to such level that it can actually impede the blood supply. It can actually impede the blood supply which goes out of the left ventricle. It can actually impede that. It can lead to sudden cardiac death. We talked about in hypertrophic cardiomyopathy, coronary vessels get affected, and this also leads to angina pectoris. And if that angina has gone up, if that angina is lasting for more than 15 minutes, myocardial death starts happening, and patient might go into sudden cardiac death. So yes, hypertrophic cardiomyopathy leads to 48% of sudden cardiac deaths. Then we have idiopathic left ventricular hypertrophy. We don't know the cause of it. Maybe it's genetic, maybe it's environmental, maybe it's epigenetic, maybe it's because of any other reason that we don't know of yet. But left ventricular hypertrophy will lead to cardiac death. Then we have coronary anomalies, which can be genetic, which can happen afterwards. Then we have ruptured aorta. Then we have unexplained deaths that we don't know of yet, and coronary heart diseases in which either there's any thrombosis or any emboli or any other coronary diseases which will lead to sudden cardiac death. So in this graph, what you have to admire is that hypertrophic cardiomyopathy and left ventricular hypertrophy lead up to 65 to 70% of sudden cardiac deaths. Next on, we have these more than 35 years of age. One thing I forgot to mention is this graph is valid for the patients who are under the age of 35 years, right? Next on, we have a graph which shows patients who are over the age of 35 years. In this way, coronary heart disease make up for 80% of sudden cardiac deaths. 5% goes for hypertrophic cardiomyopathy, 5% goes for valvular heart diseases, 5% for mitral valve prolapse, and unexplained are 5%. So the idea here to give to you is that patients who are underage, who are below 35, what's the leading cause of death? Hypertrophic cardiomyopathy, left ventricular hypertrophy. And patients who are above 35, what's the leading cause of death? It's coronary heart disease. And still, hypertrophic cardiomyopathy pays for 5%. Next on, we have sudden cardiac death pathophysiology. In uremic cardiomyopathy, what is the basic cause that lead to sudden cardiac death? We have hypertrophy, and where the size have increased due to hypertrophy of the left ventricle or the right ventricle. Mechanical dysfunction has happened. What's mechanical dysfunction? This pumping of the blood, this pumping of the heart is mechanical function. When hypertrophy has happened, mechanical dysfunction is occurring, and that mechanical dysfunction will lead to sudden cardiac death because it's going to go under ischemia. It's going to go under ischemia because of this hypertrophy. Because with hypertrophy, heart is not getting enough oxygen to function properly, and it's going under this mechanical dysfunction. So this will lead to ischemia and will lead to sudden cardiac death. And this cardiomyocyte metabolic dysfunction will come in. That will also play a role in sudden cardiac death. Next on, we have fibrosis. There were two basic pathologies we were talking about. It can either happen because of hypertrophy or it can happen because of fibrosis. In fibrosis, what happens is the electrical dysfunction comes in. In hypertrophy, mechanical dysfunction comes in. In fibrosis, electrical dysfunction comes in. In electrical dysfunction, what happens is electrolyte shift will happen. What do you mean by electrical dysfunction? Meaning that if it's fibrosed, if fibrosis has happened, all of those electrolyte imbalances, all of those shifts, all of those messages, all of those junctions which are working properly, they will go under dysfunction. They will go under electrical dysfunction, and this electrolyte shift will come in. That will lead to volume fluctuations, and these volume fluctuations will lead to sudden cardiac death. How will they lead to volume fluctuations? Actually, electrical shift and electrical dysfunctions will lead to abnormal cardiac rhythms. Those abnormal cardiac rhythms will lead to volume fluctuations, and those volume fluctuations, maybe that volume is not enough for a chamber, maybe that left ventricle is not having enough volumes of blood to pump out of it, to pump to the whole body, and that will lead to compromises on certain levels of blood supply. That can also lead to compromises on even the heart's own blood supply, coronary blood supply, and that may lead to sudden cardiac death. So this is the pathophysiology of sudden cardiac death. It can either be due to hypertrophy and mechanical dysfunction, or it can be due to fibrosis and electrical dysfunction. So that's all for this. That's all for today. And talking about these cardiomyopathies, we learned about all of these cardiomyopathies, that how dilated and hypertrophic cardiomyopathies are differentiated on the basis of their pathophysiology. We talked about how the patient is going to present to you and what are you going to pick from that. We talked about how and which cases will lead to sudden cardiac deaths, and we talked about under the age of 35 and over the age of 35, what are the leading causes of death in the patients suffering from cardiac diseases. So that's all for cardiomyopathies, and keep watching sqadia.com.